Good morning, everyone. First of all, I would like to thank Dr. Subbaya sir for giving me this wonderful opportunity to present in this ECCLIRES program, third international conference on ECCLIRES. Thank you, sir. I am really feeling proud to present in this prestigious platform. Also, I would like to thank all the organizing committee members of this ECCLIRES program, the faculties of Considered Dentistry Department, the Sri Balaji Dental College, Chennai. Power analysis or sample size calculation. Everyone knows that it is very important part of research, most critical part of a research. But the problem is it is often been neglected. The reason is due to the complexity involved in its estimation. What kind of complexity it has? Generally, the sample size calculation is something like a number game, which involves more formulae and mathematical calculations. So it appears too much of numbers appears to be scary for the researchers. Moreover, if you are going to ask about the normal distribution, a simple question, even the normal distribution will appear like a paranormal distribution to them. This road is full of mist. Though it is full of mist, we need to cross this road by understanding some basic concepts. The purpose of my presentation is to demystify the concepts involved in sample size estimation by giving some practical examples which we undertake during our academic research. Let's see through. When you start a research, the first question which is going to pop up into your mind is, what will be the sample size of my study? Do you think this question is as easy as scolding the feather? Certainly no, because the sample size calculation is going to involve many formulae. Which formula you are going to choose? We got a lot of formulae here. Which one you are going to choose from this? For example, I will show you a software. It is a commercial software available for sample size calculation, name, power analysis, and sample size. If you go to the website, it is mentioned that there are 1030 testing scenarios which can be done through this software. Now you will think the sample size calculation is very difficult, like lifting this weight. Actually, no. If you want to prepare a dish, say a vegan brownie, what you need to do is you have to read the procedure properly and you have to give adequate ingredients, all the necessary ingredients in an adequate quantity. If you're going to provide the right ingredients at a perfect quantity, you will get the right dish, right? So similarly, what you need is you have to give a proper input data to the biostatistician. So researcher has to give the input data. With this input data, your biostatistician will choose the appropriate statistical test and the formula involved in the sample size calculation. So throughout this presentation, we are going to deal only with this. What are the input data you are supposed to give for different study designs? Like all the procedures, sample size calculation also have several steps. But the problem is when a student approaches to us, he will directly think only the step 3, how to calculate. He will ask the biostatistician, I need a sample size. Forgetting the first step and second step, he directly skip to the third step. Suppose somebody is going to give a random number, take 10 per group, take 20 per group. So what will be the scenario now? Either your sample size is going to be less than the required, undersized. And if it is going to be less than the required, it is not going to be scientifically valid. Means it is not going to give any contribution to your literature, or it cannot detect any difference which actually exists. So it is again a waste of resources, right? So what will happen is the sample size is more than the record number. It will lead to ethical problem, particularly if it is a human study or animal study, it will lead to ethical problem. And there will be delay in completion of your project because too many samples is definitely going to increase the time. And of course, the cost involved in the project also going to be increased. So you have to calculate the sample size appropriately. There are many steps involved in sample size calculation. I am summarizing it as a 5 steps. First is to understand your objective properly. The second step is choose your statistical analysis. This is a very important step. Why? Because the formula used for sample size estimation is same that of your statistical analysis, which are going to use for your study design. So you need to know what is the statistical test you are going to use for your study design before calculating the sample size. The next step is estimation of the sample size by giving the ingredients like alpha, power, effect size. All these things we'll discuss. And fourth is you have to inflate the sample size considering for your dropout or design effect. And fifth is going to be your write-up. Let us see the first one. Understanding the study. This is the most important step. If you are going to do this step properly, and all the steps will be easy. First, you try to identify a specific objective as a primary objective. Then find the study design to answer your primary objective. The third step is convert your primary objective into your statistically testable hypothesis. And fourth is understand the variables for your primary outcome measure. Let us consider a research topic. A researcher wants to compare two local anesthetic drugs, say lignocaine and articaine, and he wants to test all these objectives. He wants to know the onset, duration, anesthetic efficacy, and other effects. Out of all these objectives, which is going to be your primary objective? This is the question. Let me choose anesthetic efficacy or duration, anything you can choose, but choose any one objective as your primary objective. Suppose if I'm choosing anesthetic efficacy as my primary objective, then I will be stating the null hypothesis, I will be doing sample size calculation, and I will be calculating p-value only for the primary objective. Remember, for all the secondary objectives, it is better to mention the mean and standard deviation. No need to mention your p-value because we are not stating any hypothesis per se. Why do you want to mention a p-value for your secondary objectives? It's not necessary. So primary objective, we need to give null hypothesis, sample size calculation, p-value. That's it. Okay. And once you choose your primary objective, choose the study design from your epidemiological chart. See, this chart is very familiar to you. It shows the various study designs involved in your clinical studies. Say that a biostatistician may ask you what kind of study design is it, within design effect or between the group, within the group effect or between the group effect, whether it is a superiority trial or non-inferiority trial or equivalence trial, whether it's a parallel study or crossover study or a split nose study, whether it is a cross-sectional study or a retrospective cohort study, a prospective cohort study, or a case control study. So you need to answer these questions promptly, or whether it is a one-side hypothesis testing or two-side hypothesis testing. So you have to be very thorough with your study design. So let me move into the next slide. The next slide is stating your hypothesis. As I mentioned earlier, once you decide your study design, you have to convert your primary objective into your testable statistical hypothesis. You know two hypotheses. One is null hypothesis, other one is alternate hypothesis. What is null hypothesis? Which means no difference between the two groups. Let us take an example, drug A and drug B. You wanted to know the efficacy of drug A and drug B, and you are stating a null hypothesis that there is no difference between the drug A and drug B. And what will be your alternate hypothesis is going to be there exists a difference between drug A and drug B. In other words, why do you want to research? You want to prove some difference between the groups. You will have a research idea in your mind that a particular drug A can be superior to drug B, can perform better than drug B, or drug B can perform better than drug A. We can show some difference. So this is your actual research idea. Usually, what you want to prove or what is your research idea should be your alternate hypothesis. The opposite will be your null hypothesis. Okay, so we are not going to prove the alternate hypothesis. We are going to reject the null hypothesis so that the alternate hypothesis will be automatically proved. So in general, a null hypothesis is deemed to be true. Whenever you are going to write a statement of null hypothesis, we have to think that null hypothesis is true, and we have to do an experiment. And based upon the experiment results, we have to either accept the null hypothesis or reject the null hypothesis. If you're going to accept the null hypothesis, that's it. There is no difference. If you're going to reject the null hypothesis, you are accepting the alternate hypothesis. That means there exists a difference between that. So the better way to prove an effect is to refute the null hypothesis. Okay. Coming to the variables. There are two types of variables, continuous variable and categorical variable. So let us consider our primary objective, anesthetic efficacy. How are you going to determine the anesthetic efficacy? By visual analog scale. Visual analog scale means it's going to be a continuous scale. Mean and standard deviation, it is a continuous variable. So a primary outcome measure is a continuous variable measured in mean and standard deviation. On contrary, you can measure the success of anesthesia or failure of anesthesia as a proportion. Out of 100 patients, 80 were success, 20 were failure. It is again categorical. Anesthesia success happened or not, or failure happened or not. So we are categorizing as success and failure. So in that case, we are going to give the outcome measure in proportions or percentage. So we need to be sure about what is the outcome measure for your primary objective. Now, summing up, you have your specific objectives along with your study design and hypothesis and study variables. All these things conclude your step 1. Now, if you're going to communicate these steps to your biostatistician, he will go for the step 2. Remember, step 1 is very important and step 2 is very easy. The statistician is going to pick the appropriate statistical analysis for your study design. So this is the chart, commonly used statistical test for different scenarios. So this is based upon your variables and your study design, paired or unpaired. So accordingly, you have a commonly used test. So you can choose any one particular test which is suitable for your study design. The statistician is going to help you in this procedure. Once you have chosen the study design, the next step is sample size calculation. The first step is over. First step is going to pick the statistical test. This is the second step. It's a very important step. If you're going to choose a wrong statistical test, then sample size will be wrong. So that's why I made it as a separate step. Okay. Now third step is sample size calculation. Remember, sample size calculation is not only dependent upon your statistical test employed. Even your study design and hypothesis indirectly play some role for your sample size calculation. Okay, let me see. Let us see those things. Okay. Coming to step 3. These are all the ingredients which are going to give to the biostatistician for preparing the sample size. Statistical test to be used is the something like a key ingredient, something like flour for the brownie cake. Okay, and alpha and power value. So let us see what is alpha value and power value. Whenever you look into a sample size write-up, you will see the alpha is set at 0.05 and power is 80%. What does it mean? Why they want to mention alpha at 0.05 and power at 80%? What does it mean actually? So let me show you a popular chart. This is a very commonly used chart for hypothesis testing. Here we have 4 different scenarios. 2 scenarios which is correctly matching with the reality, and 2 scenarios which is not matching with the reality. Suppose we are comparing drug A and drug B, and null hypothesis is going to be there is no difference between the drug A and drug B. In reality, there is a difference, and the test is also showing some difference between the 2 groups, which means you are correctly rejecting the null hypothesis. What is the null hypothesis? No difference. So rejecting the null hypothesis. Suppose in reality there is no difference, and your test also showing no difference. So you are correctly accepting the null hypothesis. Okay. Now We are not going to look into this correct decisions. Let us consider the false decision. What are the false decisions which can happen? Suppose there is no difference between drug A and drug B, but your experiment shows that there exists a difference between drug A and drug B, which is called as type 1 error, which means false positive. You are falsely giving a positive relationship between this drug A and drug B. That's why it is false positive. And other way around is, there is a difference, but your experimental test shows that there is no difference. In that case, you are committing a false negative or type 2 error, which means you are accepting the null hypothesis when it is actually false. You are accepting, actually there is a difference, but you are accepting the null hypothesis that there is no difference. So it is type 2 error. So why do you want to keep the type 2 error at 0.5, 0.05 and type 2 error at 0.20? Let us consider this example. Type 1 error is something like convicting an innocent. An innocent who did not do any crime has been arrested by the police. Consider this scenario. This guy is a thief and the court decided that he is not the convict and set him free. So which is considered as a serious error here? Obviously, convicting an innocent is a serious error compared to setting free the guilty. So that's why we wanted to keep the type 1 error at 5% and type 2 error at 20%. And what does it related to? What is the meaning of this? So type 1 is also called as alpha, also called as significance level. We will keep the p-value. We'll check the p-value against this significance level. We will keep the significance level at 5 and we will check whether the probability value is above the significance level or below the significance level. What does it mean 5%? Means we are giving 5% probability for the error to occur. See, remember, any study carries a substantial amount of risk and errors, but we cannot conduct a study without any error, right? So, but we wanted to keep the error as minimal as possible. So that's why we are keeping the type 1 error at 5% because it is very serious error. We want to keep it as 5%. So 5% probability of wrongly rejecting a null hypothesis when it is actually true. It is related with confidence interval 95%. If you are going to allow 5% error, it means 95% you are going to be sure. What is this confidence level indicates? 95% chance that your study finding is true and coincides with the reality. Whatever the reality, it is going to come in your experiment. Or otherwise, I can say, if you are going to do an experiment 100 times, 95% you will be right, and 5% there are chances that you may not be right, you may be wrong. So this is confidence level, 95% confidence level. And coming to type 2 error. Type 2 error is, you're going to keep it as 20% probability of wrongly accepting the null hypothesis when it is actually false. And it is related to power. When it's going to be 20%, 100 minus 20 is going to be 80. 1 minus beta is power. And what is power here? Power is, see, when you have a statistical significant difference, power matters. When there is no statistical significant difference, there is no need to worry about your power. When to worry about your power? When you want to prove a statistical significance, you have to worry about your power. Remember. So what that 80% means that there is a 80% or greater chance of finding a significant difference when there is one. If in reality, if there is any difference, you don't want to miss the difference. You want to take adequate amount of sample size to prove that there exists a difference. That's why we want to give a 80% chances to detect the real difference. So that is called as power. So what it indirectly indicates is we need adequate amount of sample size to prove the real difference. This is what it indicates. The next is effect size. What is an effect size? Effect size means magnitude of difference between the two groups. Let me take the examples, drug A and drug B. Drug A has 60% efficacy and drug B has 80% efficacy. Now, what is the effect size here? 80 minus 60 is 20% is the effect size. Simply to put, the difference between two proportions or difference between two means, is the effect size. Now we are going to look for we are going to look for the effect size rather than the statistical significance. Let me minimize this piece. We are going to look into the magnitude of the effect size. How big is the difference between the two groups? So how are you going to calculate this effect size? Effect size is calculated based upon either by pilot study. It is the best method to calculate the effect size. How did you arrive that 60% in group A and 80% in group B? You need to conduct a pilot study, right? Or you can get this information from previous literature reference, something similar to your study design. If anything is available, we can get it from your literature. If you don't have pilot study and if you don't have literature, then you can use this concept called minimum clinical difference concept. Suppose, say a control group, drug A has 60% success rate. I wanted the drug B to be at least 20% superior, or I can say I wanted the improvement to be at least 20%. Then only it will be clinically meaningful. Anything lesser than that is not going to be clinically meaningful. So you wanted the efficacy of the drug B to be at least 10% or 20% higher. This difference is minimal clinical difference. You are going to set it is based upon your clinical knowledge. If you don't have all these three, then you can go for the fourth one, which is the pre-specified threshold values for effect size, which generally not recommended and is least acceptable one. However, there are some situations where we can go for this pre-specified threshold values. Let me give you an example from our Journal of Endodontics. In this article from JOE, it is they are conducting a randomized control trial to compare the effect of calcium hydroxide alone or in combination with ibuprofen or ciprofloxacin on nuclear factor kappa B ligand and osteoprotegerine level in periapical lesions. Now, nuclear factor kappa B ligand and osteoprotegerine level. These kind of studies are kind of something like rare studies, right? So we won't be having much clinical knowledge about this. There is no pilot study because we are going to see the levels. It's going to be a long-term study also, maybe. In that case, we cannot do a pilot study. If it is going to be a long-term study, we cannot do a pilot study. And there is no available previous study means we have to depend upon our clinical knowledge. If you don't have adequate clinical knowledge on this topic, then what to do? So let us see this sample size write-up. So I'm just reading it out. There were no previous studies comparing Rankel OPG ratio among 3 independent groups, which they had chosen, like calcium hydroxide, ibuprofen, and ciprofloxacin. So any previous data could not be used in the sample size calculation. Yes, perfectly right. However, several clinical studies have used effect sizes 0.5 in their sample size calculation. They mentioned why they have used 0.5. Therefore, an effect size of 0.5, which refers to a medium effect size. See here, this is the 0.5 is a medium effect size according to the Cohen. So they are using it. 0.5. They are going to use the 0.5 as a medium effect size, and they are given a write-up as follows. The sample size calculation is based on error of alpha 0.05, power at 8%, and the effect size is 0.5. Indicated that each group should include minimum of 19 patients. So here the sample size is purely based upon the pre-specified threshold levels. It is not based on pilot study, not based on previous studies, not based on the clinical knowledge. It is based upon Cohen's D's suggestion. So I just want to give this example to you. Actually, this pre-specified values varies for each and every test. For t-test, chi-square, ANOVA test, it varies. Okay. Now the next is, now you understand the importance of effect size. Now there is a $1 million question, which is very important. Effect size is important, or p-value is important, or statistical significance is important. I will give an example. So, a study says that massage improves sleep compared to the control group. They have included 10,000 samples and proved that it is statistically significant in improving the massage. But what happens is the effect size is how much, what is the duration of the sleep between these two groups. What is the effect means 47 seconds per night. So means the massage group slept 47 seconds extra compared to the no massage groups. Do you think it is clinically relevant, important? You have a statistical significance here, but it is not clinically very meaningful. So what we have to understand from this is, if you're going to take a large or very large sample size, even a small effect size can be proved to be statistically significant. Let me give you another example. A study says that massage does not improve the sleep when compared to the control group. They included 100 patients and failed to prove the statistical significant difference between the two groups. And what is the effect size here? It is 1 hour longer. The massage group slept 1 hour longer. But do you think 1 hour longer is clinically important per day? Yes. If they sleep extra of 1 hour, it is very important. In that case, the sample size is inadequate to prove the real effect, or I can say the study is underpowered. So this is a classical example to prove why you need a sample size determination to prove a real effect, real clinical effect. Okay. So now coming to the question, which is important, statistical significance or effect size? Statistical significance simply means that there exists some difference statistically or mathematically. But clinically speaking, a difference which makes no difference is no difference at all, right? So what makes a difference? It's the effect size. The next point is one-sided and two-sided hypothesis. You need to understand when are you going to use a one-sided hypothesis or a two-sided hypothesis. Let me pose a research question. To compare the efficacy of brufen and diclofenac in management of post-endodontic pain, let us consider a conventional two-sided hypothesis testing. Null hypothesis, no difference between brufen and diclofenac. And alternate hypothesis is there exists a difference between brufen and diclofenac. The difference may be either side. Brufen may be superior or diclofenac may be superior. We don't know that. So we are testing the hypothesis on either direction. Whereas in a one-sided test, we are going to test the hypothesis in only one direction. Diclofenac is superior to brufen. This is the hypothesis we wanted to prove, or this is a statement we wanted to prove. Diclofenac will be superior to brufen in post-endodontic pain. And what will be an alternate hypothesis? Diclofenac is not superior to brufen. Here we are testing the hypothesis towards one direction. That is called as one-sided or one-tailed test. Step 4 is accounting for the dropouts. In any study, we can expect a dropout due to many reasons. First of all, the patient may not be interested in participating or continuing the study further, so he may go out. Or there may be some protocol failures, like if you open access and you found that it is non-vital, you cannot include that case for anesthetic efficacy assessment. So it is a protocol failure, so you can remove that. Or sometimes the patient may not be available to give the repeated measures readings, or there may be some incomplete data. In those cases, we have to consider as the case as a dropout. So how to adjust for the dropout? We have to inflate the sample size, anticipating the dropout rate. Let me give you an example. Your calculated sample size is 20, and you are expecting a 10% of dropout. If 10% dropout means how many percent is respondent? 90% is respondent. By using this formula, inflated sample size is equal to calculated sample size by respondent percentage. So 20 is a calculated sample size divided by 90% is equal to 23 samples. So we have to inflate the samples from 20 to 23 to adjust a dropout of 10%. The next is write-up. How to give a write-up? As I mentioned earlier, the sample size write-up should be very clear. You should give all the details so that the reader should understand, and most importantly, he has to recreate the same. Let me give you a beautiful example from International Endodontic Journal. The authors have conducted a randomized control trial where they compared two groups, post-treatment endodontic pain following occlusal reduction in mandibular posteriority with symptomatic erosive palpitis. So what they have done is, after the root canal treatment, it is not with the root canal treatment. A patient who is having symptomatic erosive palpitis, they are reducing the occlusion. And for one group of patients, they are not reducing the occlusion. They wanted to know whether the occlusal reduction reduces the post-endodontic treatment pain. Now let me read the sample size estimation. Sample size estimation was performed based on alpha at 0.05, power set at 98%, indicated that so much amount of patients, 274% and 137 would be required to detect a minimal clinically important difference of 23% in post-operative pain incidence between the groups. Information obtained from the previous studies indicated that anticipated post-operative pain incidence of approximately 48% in the control groups. References Rosenberg and Falco. Now, the author has taken this value, 48% is the incidence of post-operative pain in the control group from two reference articles, previous articles, as 48%. And they wanted this 48% pain incidence to be reduced to 25%, and they have mentioned minimal clinically important difference to be 23%. So let us try to recreate it using a software PASS. Okay, this is based upon the proportion, right? Two group proportion. So let us go to procedures. It is proportion based study, right? Proportions, two independent proportion, test inequality, test for two proportions. So what is the power they have kept? 98% power and 5% and 48%, and the minimal is 23%. Let us feed the data here. So 98% is power, 5% is your alpha error, and based upon the proportions, 48% is the pain incidence in group 1 and 25% is a pain incidence in group 2. How it is 25%? 48 minus 23. They want the minimal difference to be 23. So 48 minus 23 is 25. In other words, they wanted a 75% of the treated patients to be pain-free. So 25. Let us calculate. And what is the dropout percentage? Is 10%, I believe, right? So let us go to the dropout. I am keeping as 10%. Okay. So calculate it. So what is the sample size required is? So we need 138 samples, 138 samples. Adjusting for the dropout, what is 154 and 154? It is 308. Let us go and check the data. It is 308. Now we can recreate it. So the authors have mentioned the reference article and the softwares used, all the relevant details. So we can easily recreate it. So this is how a proper write-up should be. Now let's move on to the next section. Now we completed the theoretical part. Let's go into the practical aspect of the sample size calculation. Let me try to give you some examples based upon some commonly conducted research questions, so that you will come to know what are all the input data you have to provide to a biostatistician. Let us consider first question. Researcher wants to compare the success rate of novel method of local anesthetic administration technique with that of inferior alveolar nerve block. Now IANB is the control group. The researcher wants to compare the success of a new technique, whether the anesthetic efficacy improved or not. Now what kind of study is this first? Success rate. It is based upon the proportion and between two groups. So the study is difference between two proportions. Let me keep it here. Difference between two proportions. Now, what are all the input data we have to give? We need to give power at 80%, alpha at 5%. You can change it 80 to 90, 99, anything. Alpha at 5%. Success rate in control group based upon the previous studies is inferior alveolar block is 62% success. And the researcher wants the success to be at least 80%. They wanted the minimal clinically acceptable difference to be 18%. So with this novel technique, so let us try to calculate sample size using G-Power software. Let me open a G-Power software. So sample size is going to be based upon the proportion, two independent groups. Fisher x-axis is the statistical test we are supposed to use. It's a two-sided test. What is the proportion for the first? It is 62%. And what is the proportion for the second group? It is 80%. 62 plus 18 equal to 80%. 80%, and alpha at 5 and power at 80%, and allocation ratio 1:1. So it is 109, 109. Total is 218%. Now 218 patients is required to prove the statistical significance. Now you have to account for dropout 10%. Unfortunately, this software is not having the allowance to adjust for the dropout. So let us calculate it manually. Open the calculator. What is the sample size? Total sample size is 218. 218. What is the dropout rate is 10%. So what is the respondent rate? 90%. So 218 divided by respondent rate 0.9 is equal to 243 per two groups. So it is for event considerations, we have to make it 244. We need 244 subjects, or I can say 122 subjects per group to detect the statistical significant difference between these two groups, considering a dropout of 10%. The next scenario, researcher wants to study the impact of topical application of clove oil on the pain experienced before and after its application in patients with symptomatic erosive pulpitis using VAS scores. Now, the idea here is it is before and after application of clove oil in pulpitis cases. It is a pre-post design. So it is a within the group design, or also called as paired group design. So difference between two means. Why it is mean? Because we are going to assess the pain using VAS scores. VAS scores is mean and standard deviation. So difference between two means, and it's a paired data because of pre-post design. What are the input data needed? Power 95%, alpha 5%, mean VAS score for before the topical application is 8.1, and after topical application is 3.9. So the pulpitis pain is 8.1, and after application of clove oil, the pain is reduced to 3.9. This data is based upon the pilot study conducted among 8 patients. So what is the mean difference between 8.1 and 3.9 is 4.2, and the common standard deviation or pooled standard deviation for 5.1 and 3.1 is approximately 4. Let us calculate this through PASS software. So procedures. What is the study? It is based upon mean. It is paired means. It is t-test. It is paired t-test. So let me feed the data. How much power we need? I want 95% power and 5% statistical significance, right? And 4.2 and 4 is the standard deviation. So let me calculate. I am not considering dropout here because it is pre and post design, so immediately we can follow. So I am not considering a dropout in this case. Calculate. If you don't, there is no chance of dropout means you can skip that step. So we need 14 patients to test the statistical significance. How many had taken in the pilot study? 8 patients. So how many more we have to take? We have to take 14 more patients to detect the statistical significant difference. Now the next scenario is, now the researcher wants to compare. It's an in vitro study. Majority of us are doing an in vitro study, so I am giving an example for in vitro study. Researcher wants to compare the efficacy of fluoride and nanohydroxyapatite on enamel remineralization in vitro using Vickers hardness number. Vickers hardness number is a mean. The outcome measure is a mean. So it's a continuous outcome. And how many groups we have? 2 groups. So what is the study? Difference between two means unpaired. We are going to use separate blocks for fluoride and separate blocks for nanohydroxyapatite. So it is unpaired means. What are the data needed? 90% power, 5%. Based upon the pilot study with the 12 samples, we calculated 250 and 270 with plus or minus 20 and 23 respectively. If you're going to feed this information in G power, we'll get the sample size. Let me go through the next slide. I will do the sample size calculation for this example. Here, this is something similar to the previous design. The only difference is we have 3 groups: fluoride, CPP, ACP, and nanohydroxyapatite using Vickers-Corners number. The same in vitro design, but only difference is you have more than 2 means, ANOVA design. So what are the input carrier? Same power alpha. You need mean values for 3 groups and standard deviation for all the 3 groups, or a common standard deviation for all the 3 groups. So here I am mentioning a common standard deviation for all the 3 groups. Let us calculate the sample size using G power for ANOVA design. I am opening G power, going to F test family. F test is ANOVA family. And I want to determine the effect size. So if you see, before determining the effect size, if I'm going to place a cursor here, it is showing effect size as 0.10, 0.25, 0.40 based upon the coherence T. Okay, just I wanted to show this. I told no, the fourth least acceptable way of taking the effect size, this one. So this is for ANOVA design. Okay. Now I am going to calculate the effect size based upon the pilot study, which is most authenticated. How many groups we have? 3 groups. What is the common standard deviation? We have 32. And what is the mean value? 250.4. 250.4. And what is the next group? 276. And what is the next group? 289. And what is N is 8 per group. So I am applying equivalent. So all will change into 8. So total sample size after 24. I am calculating the effect size. Effect size 0.50. Now I am calculating this effect size to the main window. Yes. What is the power here? 90. Okay, I'm converting the power, change the power to 90. Number of groups 3, alpha value 0.5. Effect size we have calculated from the pilot study, and power 90%. Let us calculate the sample size. Sample size is 54, which means 18 per group is going to give the adequate statistical significance. Now 18 per group for microharness. Some students may feel that 18 is too much for me. I wanted sample size for only for 80% power. Yes, okay, it's well understood. Some researchers may feel that my study is funded. I wanted to have a high power for my study. I wanted 95% to 99% power. So let us calculate varying sample size for different situations. Let me plot a thing. Now I wanted to create a graph and table. From 80 to 99, I wanted to know the sample size for varying powers, and you can even control your alpha value also. I want sample size for varying alpha. So let me draw a plot. So let us go into the table. See here, for 80% power, if alpha value is going to be kept at 0.01, the power is 60, and for 5%, the power is 41.514. So for a student who cannot afford much, she can keep the sample size at 42. Overall sample size, I mean 42. Suppose if a researcher wants the power to be highest and error, he wants to minimize the error, he can say 95% power at 1% alpha level. He can choose this sample size. So, and this is a graph which shows how your sample sizes increase as the power increases. That's it. Okay. So let me Go to the next example. The next three examples are very important clinically because majority of us are conducting a superiority trial. But there are some situations where we can conduct a equivalence trial or a non-inferiority trial. So let me explain what is a superiority trial, how to calculate a sample size for a superiority trial. The previous examples, what I have shown is an inequality. We are testing on both the sides. We are not checking superiority of any particular product. Here, we are going to specify, I am going to check the superiority of one particular drug by some superiority margin. This is the difference. So just look into the research question. The researcher wants to prove the superiority of combination of brufen, paracetamol and caffeine over brufen alone in the management of post-endodontic pain. See, the researcher wants to prove the superiority. So it is clearly a one-sided hypothesis. Now, it is based upon proportion. Yes, pain present or absent proportion, and it is a superiority trial. What are all the input details we need to give? Apart from the routine, we need to give a superiority margin. This is very important. Now, power is 90% and alpha is 2.5%. Remember, if it is going to be a one-sided hypothesis, it is better to keep your power at 90 and alpha at 2.5. Instead of 5%, we are reducing the error to 2.5 because it is a one-sided hypothesis. So we don't want to take much chance to eliminate the bias. Okay, so we are keeping 90 and 2.5%. And superiority margin is 10%. This is something a tricky one. Here we are going to test the hypothesis that I wanted to prove the synergistic effect of this combination is at least 10% superior over brufen. In reality, a brufen, it may give 80%. The difference may be 55 and 80. It is almost like 25%, I believe. In reality, the difference may be 25%. But we don't know exact reality. It is going to occur in our studies. Based upon the previous study, the imol plus is giving 80% pain relief. Based upon previous study, the brufen group is giving 55% pain relief. The actual difference is 25%. But if you want to prove the superiority using a randomized control trial, we can keep a superiority margin, say 10%. So let me feed the same data with a 20% dropout. I'm going to conduct a superiority trial sample size calculation procedures. Go to superiority by a margin. It is a proportion, right? Proportion, two independent proportions. Superiority by a margin, difference between two proportions. Okay. Let me fine. It's 90% power. Power is 90%, and alpha is 0.025%. And proportion of success in brufen group is 55%. And actual proportion of success in imol plus group is, that is synergistic effect group, is 80%. And but the researcher wants to prove at least 10% superiority margin, and he wants to test that hypothesis. It's not null hypothesis, something different here. Okay, so he kept the superiority margin at 10%. So it is 55 plus 10 is 65%. And what about the dropouts? Dropout is 20%. Yes, okay. Let us calculate the sample size. So we need at least 191 samples. And considering the dropout, we need 239, 210, 478 samples, 239 per group, to prove that imol plus is superior over brufen in post-endodontic pain management. This is very important. Okay. So if you have a thought of considering some superiority trial, we have to do a sample size in this way. So what the researcher has to give is superiority margin. In the same way, we need to give equivalence trial and non-fatal. We have to give a equivalence margin and non-inferiority margin. Now I am going to explain about a equivalence trial. Let me read the question. Researcher wants to test whether efficacy of platelet-rich fibrin is equivalent to MTA in terms of dentin bridge thickness formed over a period of 6 months. Now, why the researcher wants to conduct a equivalence trial? See here, the platelet-rich fibrin is cost-effective compared to MTA. See, it's only assumption. I'm just thinking that the researcher is thinking that PRF is easy to take from the blood sample, and we can centrifuge. It is cost is very less compared to that of MTA. the patient cannot afford, some patients cannot afford for MTA. So he wanted to find an alternate material. The alternate material should be equivalent to that of MTA. It should not be inferior. So this is an equivalent trial based upon mean, because dentin bridge thickness is measured in mean. Assume MTA results in 30 microns dentin bridge formation over a period of 6 months. Now, how much equivalent margin I have to give for PRF? I can say plus or minus 10 microns excess or less. So what I am giving is, let me take a power at 80% and alpha at 5%. The equivalence margin I am setting at plus or minus 10%. Why it is plus or minus? It may be the, who knows, the PRF may be superior to MTA or PRF may be inferior to MTA. If it is going to be superior to MTA, we need to think about PRF in future rather than spending much money on MTA. Am I right? Yes. So we don't know whether MTA is going to be, PRF is going to be superior or inferior, but we want to prove that fact that PRF is equivalent to that of MTA. So I am keeping a, but based upon the clinical assumption, I want to be 10 plus or minus 10. Suppose it's 30 means 20 to 40 is the range, equivalent range. Okay. And based upon the previous study, we came to know that PRF results in 25 microns thickness. See this 30 and 25. It is lesser than that, but it is not lesser than our equivalence margin. Let us see, if we want to test the hypothesis, how many sample size we need. Let me open the equivalence. Procedures, equivalence. Equivalence means 2 independent means, 2 samples accumulating equal variance. So values are already fed here. Let me tell you what are the values here. Sorry. 85 and plus 1. So 80 is a power 5 and the equivalence margin is plus 10 and minus 10. And the actual difference between the two groups based upon the pilot study is 30 minus 25 is minus 5. Okay. So I mean 25 minus 30 we have to in the reverse direction. And the standard deviation obtained is 6.1 and 5.4, the common standard deviation. Let us assume 5.5. Okay. And reports 20% dropout. And it shows that we need at least 16 in case in both the groups, 16 in each group, total 32 to prove the statistical and accounting for the dropouts 2020. Totally 40 sample sizes required to prove that PRF is equivalent to MTA. Right? The next study design is non-inferiority design. Now, why do you want to conduct a non-inferiority design? So let us consider this example. A researcher wants to prove that antibacterial efficacy of modified triantibiotic paste is not inferior to conventional triantibiotic paste when used as an intracanal medicament. Antibacterial efficacy of two groups. One is conventional triantibiotic paste, another one is modified triantibiotic paste. Why do you want to introduce a modified triantibiotic paste? Considering the tooth discoloration side effect of your minocycline in TAP, the researchers want to reduce the concentration of minocycline and they named it as modified TAP. Now, they felt that modified TAP is not causing tooth discoloration. Now, they are worried about whether the antimicrobial efficacy of this modified TAP is should not be inferior to that of your conventional TAP. So they wanted to conduct a non-inferiority trial. So this is non-inferiority trial based upon proportions. So now the power is 90%, alpha is 2.5%. Again, it is a one-sided hypothesis. So I kept the power and alpha value at highest, alpha at lowest and power at highest. Okay. Non-inferiority margin 80%. But let me first the antimicrobial efficacy of control group is 97%. With 97%, it eliminates all the bacteria. So based upon the previous study. Now I wanted the modified triantibiotic paste to be at least 80%, not inferior to that of 80%. If the antimicrobial efficacy is going to be less than 80%, I consider this modified paste is inferior to the tri-antibiotic paste, so I will not recommend it as an intercombinant medicament. So I want it to be at least 80%. But previous studies says the actual effect of modified tri-antibiotic paste found should be 92%. So I want to calculate the sample size considering a dropout of 10%. Let me calculate an non-inferiority trial. The reason for focusing towards the superiority, non-inferiority, and equivalence trial is the knowledge of these trials is very less among the dental fraternity. So I am giving these examples specifically. So a non-inferiority based upon proportions, two independent proportions, test between two proportions. So what is the design here? 90% power, 0.025. The success rate in tri-antibiotic paste is 97%. Actual success rate in modified paste is 90%. But the inferiority margin, non-inferiority margin, we want to choose is 80%. And the dropout is 10%. Let us calculate the sample size. So 76, 76, 152. And according for the dropout, we need at least 85 per group, 85 per group to prove that modified tri-antibiotic paste is not inferior to that of your conventional tri-antibiotic paste. Okay. So let me go into the next study design. Now it's an example for a case control study. Researcher wants to find the odds of vertical root fracture in endodontically treated tooth. You know very well endodontically treated tooth is more prone for vertical root fracture. What is the chance of getting the VRF in an endodontically treated tooth compared to a non-endodontically treated tooth? VRF can occur in a sound tooth as well as a treated tooth. So what is the odds of getting VRF in your case group? This case group is RCT treated group. This is case control study based upon the proportion. What is the case here? Case is VRF. What is controlled here? Patients who do not have vertical root fractures. Now, what we need to do is they are conducted based upon the previous study. They found that the percentage or the proportion of the patients exposed to root canal treatment in control group to be 21%. Control group is no VRF group, whereas the proportion of patients who exposed to root canal treatment in VRF group is 74%. Now they have got this data. So actually no need to provide odds ratio. If you have either two proportions or any one proportion and one odds ratio, you can calculate the sample size. Okay, let us try to calculate a sample size to prove this odds to be statistically significantly different. I'm going to use the software OpenAP. This is OpenAP software. I'm going to sample size, unmatched case control study. I'm going to enter the result. 95% is confidence level. It is alpha. Alpha is 5%, 80 power. Case to control ratio, let us keep as 1. As long as there is no problem in selecting a cases, we can keep it as 1. Okay. And what is the percent of controls in exposed group? It is, I think, 21%. And percent with exposure is 74. Am I right? 21 and 74. And what is the odds ratio is 10.7. See, the odds ratio has been given here. Okay. It's not necessary that we have to give odds ratio, as I said mentioned. Any two proportion or one odds ratio and one proportion is sufficient. Let us go for the results. We need at least 14 cases and 14 controls to prove the odds of 10.7 to be statistically significant. This is the way we have to calculate the sample size for case control study. And the next example is animal studies. The sample size calculation for animal study is something similar to our clinical study only, but we have to consider two things. One is ethical concern. Unfortunately, the animal subjected to the studies, means animal in the trials, they face substantial mortality or substantial morbidity or mortality. We may have to sacrifice the animal, or they have to face substantial morbidity. So it is ethically is an important concern. And moreover, this is a disadvantage fact. The advantageous side is all the animals are grown in the same place, so it has a similar genetic background. So the results is not going to vary from animal to animal. Considering these 2 points, we can take fewer animals. So we have to consider only fewer animals. Fewer animals is sufficient because genetically similar. It is going to provide similar results. There is variation is going to be very less. Moreover, considering this ethical concern also, we have to choose only fewer animals. So here, ethical consideration is more important than the statistical power. So they have given some formulas for calculating the sample size. Sorry. Let us consider a study design. A researcher wants to compare the efficacy of 3 different graft materials on induced bone defects in the femur bone of monkeys by assessing the bone density using CT scan. Here we have a substantial morbidity to the animals. Who knows, sometimes they may sacrifice animals too. In that case, what is the sample size? 3 different graft materials. So more than 2 groups is a group comparison ANOVA. So let us use this minimum groups and maximum sample size per group. 10 by k plus 1 and 10. Let us apply. How many groups you have? 3 groups. So we have 5 minimum sample size and 7 maximum sample size. So 5 to 7 per group is needed to test this difference. Similarly, if you have a repeated measures or a mixed design, we can calculate the sample size for animal studies using this formula. So summing up, we have to understand the study objective clearly, choose your primary objective, choose the appropriate study design, state your null and alternate hypothesis depending upon the study design, know your variables, whether continuous or categorical, how are you going to measure your outcome measure. Give it to the statistician, he will calculate the appropriate statistical test. He will find the appropriate statistical test and give the formula. And you have to give alpha and power. You can give it from the previous example. If it's superiority trial or non-inferiority trial, give alpha 0.025 and power at 90%. Otherwise, you can keep the power at between 80 and 99, and alpha between 5% and 1% anywhere. And effect size, this is very important. You need to mention the effect size and how it is calculated, whether from the pilot study or previous study or clinical knowledge or Cohen's d or the pre-specified threshold values, and mention whether it's one-sided or two-sided, as I mentioned earlier, and account for the dropouts. And finally, give a write-up clearly. Mention your alpha power, mention your effect size or minimal accepted clinical difference. Most importantly, mention how did you calculate the effect size, whether from pilot or previous or clinical knowledge or Cohen's d. Mention the anticipated dropout percentage and inflate the sample size accordingly, and mention the software used. This completes your write-up. So remember, the sample size calculation is something like a mini study. If you do it properly, almost 75% of your research work is completed. Assume that. Okay. So plan it before your study properly. Thank you so much for patient listening, and Jai Hind.
Thank you, Dr. Srinivasan sir, for turning our attention to and enlightening us on sample size estimation as an essential component of research. Let us now invite Dr. Srinivasan sir and Dr. Mahalakshmi ma'am to address the audience questions for this session.
Wow, Srini. Thank you so much, Dr. Srinivasan, for that wonderful insight on sample size calculation. And I'm sure all the postgraduate students who are listening to this would definitely, understand how to calculate sample size, importance of doing it right from the beginning of the, before the beginning of the study, go to a statistician before they, with their objectives. I always have found, statistics to be very boring. I have attended so many lectures, and every time I understand it perfectly, but when it comes to actual use of statistics, I'm always a novice. So thank you really for putting up a very good, with examples. That's the main aspect. So as I said, an endodontist being a biostatistician actually helps a lot. So you have given each and every point of how to calculate a sample size based on the study design. So that actually will help everyone very much. So thank you once again for that wonderful lecture. We have a couple of questions for you. Some of them actually are a repeat of, you've already taken it up in the lecture, but I think one more explanation definitely is called in for. So I'll start with the first question. Now, how do we see if we do not have any previous studies and we always do a pilot study? So how do we determine the sample size for a pilot study? How many, samples to do?
Yes, ma'am. Good morning, ma'am.
Good
The
morning.
question is regarding the pilot study. How many samples to be taken for a pilot study? Ma'am, the main purpose of doing a pilot study is not only for a sample size calculation, mainly to know the feasibility of the study, ma'am, whether the study is going in right direction or not. And sample size calculation from the pilot study is one of the additional step. And coming to how many numbers we need, ideally speaking, they say 12 per group. Why 12 per group is we need to calculate the effect size, and the effect size which we are calculating from the pilot study should be at least near to the sample population, I mean our study population. So I suggest to keep 12 per group. In case if you anticipate that the effect size between the two groups is going to be really more, then you can reduce it to 8. So 8 to 12 is the ideal limit.
Okay. So in cases where we have to say, for example, in randomized controlled trials, right? So when we do a pilot study, we actually do not randomize them, right? We have to do each sample for each group. So as you said, if you have to do 12, then that effectively becomes, suppose it's the sample size itself is around 15. So randomization cannot be done in that case.
Ma'am, actually we can do a block randomization procedure. Actually, for randomization procedure also, you have to contact a biostatistician, and you have to keep a particular number in mind. Say I'm going to take 24 samples for 3 group designs, which is going to be 8, 8, 8. So what the statistician will do, he will do a block randomization and allocate each and every sample equally to all the 3 groups, ma'am.
This is also a pilot study?
For the pilot study, block randomization is applicable for the pilot study. The point is, whatever the samples you are going to take for your pilot study, you can take it for your main study. So you have to conduct your pilot study similar to your main study, except the sample size is very low. That's it. That's the only difference.
Yeah, so that's exactly what I wanted to know. How to determine the sample size if multiple variables are evaluated?
Yes, ma'am. Multiple variable means what? I don't know what exactly the person is asking me.
Groups
So let
and
me.
groups, parameters are many.
Yes, ma'am. Okay, ma'am. Suppose, say, if you are going to do a regression analysis where the number of independent variables to be tested against a different variable is many, say, for example, 6 or 7 variables. In that case, there is a thumb rule where we have to take at least 10 samples per variable. So totally, suppose if you have 6 or 7 variables, we can take 60 to 70 as a minimal sample size. If you are not able to calculate the sample size because we have multiple variables, we can go with this, ma'am. Similarly, the same thing applicable for logistic regression. For logistic regression, at least we have to inflate the sample size because the outcome is binomial in nature. In a linear regression, the outcome is continuous in nature. So we can keep it as 10 or lesser than that too. But for logistic regression, we need to inflate it more. If you have multiple variables, for example, I can give a survey. In a survey, if you want to check the knowledge and attitude of a particular topic among the dental professions, we have to give some questions, say 20 questions. Each and every question is considered as variable. In that case, we have to take at least 5 to 10 samples per variable. So it is depends upon the variable. For multi-variable studies, it is a thumb rule, ma'am. We can go with that.
Okay, thank you. Actually, you have explained this, but someone wants it. Can you explain effect size with an example?
Effect size.
Do you want to take it up again or?
What is the question, ma'am, please?
Can you explain effect size with an example?
Yes, ma'am. Effect size is the difference between the two groups is the effect size. For example, I have shown an example. The pain in group A is 8.3, and in pain in group B, we are giving some treatment. The pain has reduced to 4.3. What is the difference here? 8.3 and 4.3. The difference is 4. The 4 is the effect size, ma'am. Actually, technically speaking, the effect size involves difference in the means and the standard deviation involved in each group. But for understanding sake, I am just putting it as just different. Mathematics, I don't want to go deep into the effect size. So for understanding purpose, to make it short, it is difference between two groups. What is the amount of variance effect difference between group A and group B, or a drug A and drug B? That is the effect size, ma'am. And this is very important parameter to calculate the sample size.
When there are two null hypotheses in a study, for which one do we set the p-value, or can we have p-value for both?
If you have two null hypotheses, which means that you have two primary objectives. Yeah, one primary objective can have only one null hypothesis and one alternate hypothesis. So the question is here, if you have two null hypotheses, in that case, you have two primary objectives, and you wanted to consider both the objectives as equal primary objective. In that case, sample size has to be calculated for individual primary objective. Whichever is larger, we have to take that.
Okay, you got it. There is one last question, but you have actually addressed it very well. But how do we calculate sample size when there is no previous data? So right from pilot study to effect size.
Yes, ma'am. I will repeat it. The best way to calculate the effect size is from the pilot study. In certain circumstances, we cannot compute pilot study, or if you have literature available from the previous studies, no need to waste your resources by conducting a pilot study for sample size purpose, I mean to say. So in that case, now the scenario is you don't have previous study, and it is something like a long-term study where you cannot conduct a pilot study too. So what we have to do is we have to use a concept called minimal clinically acceptable difference. For example, you have two groups. You know the efficacy of the root canal treatment is going to be 70% success. And you want to improve the success rate of root canal treatment by introducing some new sealer, say bioceramic sealer. And you are anticipating this bioceramic sealer has more potency, and definitely it is going to improve the success rate more than 70%. So if more than 70% means, based upon your clinical knowledge, we have to think how much percentage success is considered to be clinically meaningful. Say 10% success from 70 to 80. So now here I am keeping 10% as minimal clinically detectable difference. Yeah, 10% success is something great from the 70, right? So if I want a difference between 70% and 80%, what will be my sample size? This is called as minimal clinically detectable difference. It is purely based upon our clinical knowledge and a guesstimate. This is good point. Suppose if you don't have all these three things, we have to go with Cohen's D, that pre-specified threshold levels. I have shown an example from Journal of Endodontics. From that, we can choose that. If you don't have any knowledge, we can go with that. These are the only 4 ways we can choose the effect size.
Okay. One last question. Is there any criteria for selecting articles which can be used for sample size calculation? And how many articles have we to source in that case? How many articles will we select?
Ma'am, it is it can be 1 or 2 or 3, anything, ma'am. The point is the group should be similar to the study which you are going to do, ma'am. Suppose if you have group 1, group 2, group 3, to calculate the mean and standard deviation, you can refer one article. For example, fluoride microhardness, you can take one article, article number A. The fluoride would have compared with CPP-ACP, you can take the CPP-ACP microhardness from the article number 1. Now you wanted to know the microhardness values for nanohydroxyapatite. You can take article number B. Another author had compared a fluoride with nanohydroxyapatite. You can take that. So it depends, ma'am. The only thing is the product, the concentration, everything should be similar.
Similar.
This is
So
the only thing we have to.
Certainly be comparing the same materials. You can take from different sources.
From different articles. We can take from different articles. I have shown an example. The author has mentioned 2 reference articles for previous study examples. From International Aeronautic Journal, he mentioned 2 reference articles for that. So we can do that, ma'am. But only thing is the concentration, the product should be similar. That's it.
This question was from Dr. Vidya. There's one more question from Dr. Karthikeyan. He says, very nice presentation, Dr. Srini. Recently, I attended one lecture on statistics in that the presenter told that null hypothesis should not be stated in a negative way. The statement should have no or not. Kindly clarify. There's an alternate hypothesis also. So can we propose an alternate hypothesis? Do we be biased if we do so?
No, ma'am. We have to propose the null hypothesis. Even if you're not going to propose alternate hypothesis, we will take it as inequality trial. You can propose alternate hypothesis. Indeed, what alternate hypothesis is, what research idea you have in your mind is going to be your, what you want to prove is your alternate hypothesis. But we are not going to test the alternate hypothesis directly because it is biased. So what we are going to do is, we have to propose a null hypothesis, making a statement that there is no difference between the groups. We have to keep that thing in my mind. And we have to assume that null hypothesis is true till you complete your study. Once you got your study results, based upon the study results, either we are going to accept the null hypothesis or reject the null hypothesis. If you are going to accept the null hypothesis, there is no difference. We can keep it. If you are going to accept the null hypothesis, reject the null hypothesis, now the alternate hypothesis or our research idea is proved automatically. So the point here is, I want to tell to Dr. Saravana Karthikeyan, we need to propose null hypothesis, and it is always no difference in inequality trials. And we have to reject the null hypothesis to prove your alternate hypothesis. This is the way. And
thank you so much, Dr. Srinivasan. Actually, we are running very late. I think so. We are running.
Yeah.
So I end my questions here. I would like to really thank you for your patient explanation. I know you have lots to offer. And also I would like to thank Dr. Subbiah and Team ECCLIRES from Sri Balaji Dental College for giving me this opportunity. Over to you, Dr. Dr. Subbiah.
Good. I profoundly thank Srinivasan for giving a long lecture on this and taking a lot of time to explain each and every question. Very nice of you to have really explained it in detail, especially again in the question and answer session. They explained in detail. I'm sure the often neglected part of the research, the sample size, would gain importance after this and infuse the importance into the young research minds, the importance of sample size. Before we thank you for the long lecture and well explained question and session. I also immensely thank